All right, health care legislation moving forward this past weekend in the House and could face a Senate vote as early as next week. But some skeptics say the legislation is just too costly for an economy already stretched thin, and a lot of those skeptics are Democrats. For more on that, let's go to the White House, where White House Budget Director Peter Orszag is standing by. Peter, thanks for joining us. Let me ask you, first of all, what you say to the sort of growing revolt here of people in your own party who are saying this is going to cost too much money.
Well, I'm not sure there is a growing revolt. If you look, for example, at the package that the Senate Finance Committee put together, not only is that deficit neutral over the first 10 years that it exists, it's deficit reducing thereafter, and it includes a whole variety of very important changes that will make the healthcare system more efficient and promote quality over time.
We're looking at the House bill clocking in at $1.2 trillion. That's more than the president had hoped for, to the tune of $200 billion, which is still, Peter, a lot of money, even though it doesn't seem like it after this crisis, right?
Let's be clear. The House bill also is actually reduces the deficit over the first 10 years of its existence. It does reduce the deficit further in the second decade. It's fully paid for, and it, too, includes a whole variety of changes that are not counted in those numbers that will help promote quality over time, discouraging unnecessary hospital readmissions, encouraging bundled payments, which will help provide a more effective healthcare system over time, and a whole variety of other changes, too.
Peter, let me ask you, because I think beleaguered taxpayers after the last year or so are so tired of putting out money to pay for one crisis after another. Can you tell us without any doubt, 100% certain, that no taxpayer funds will be needed to pay for health care reform?
Well, there may be some revenue that's part of the equation, but it will be deficit reducing. And with regard to the underlying deficit, let's remember where that comes from. We're projecting a $9 trillion deficit over the next decade. That comes from basically three sources. One is the failure to pay for policies in the past, $5 trillion because we didn't pay for the Medicare prescription drug benefit, and we didn't pay for the 2001 and 2003 tax cuts. We're paying for this new health reform proposal. Second, $3.5 trillion because of the severe economic downturn, and less than a tenth from the Recovery Act, the steps that were necessary to address that downturn. So we do face a significant fiscal hole. We're going to have to work our way out of it, but it's important to remember where that comes from, too.
What is it about this model that makes you so optimistic you can reduce costs? When you look overseas at the model, a national health care model in England or in Germany, where they just see costs escalating out of control, I mean, what is different about your proposal to all the other national health care models that are just unsustainable?
Well, I think if you look at a variety of sources, whether it's the Dartmouth, the Wenberg Center at Dartmouth College, the McKinsey studies that have been done, the Institute of Medicine, there are a whole variety of analyses that are suggesting significant amounts of money can be saved, as much as $700 or $800 billion a year, from cutting back on healthcare services that are delivered that don't actually improve health. I mean, a small example, as one example. If you suffer from arthritis in your knee, there's no evidence that actually having surgery is better than physical therapy and management. It costs a lot more, but it's also more of a pain for you and doesn't actually generate better results. We need to be moving towards a healthcare system in which we're emphasizing quality rather than just more. And all of the evidence suggests that there's huge opportunities to capture that will allow us to move towards a more cost-effective system.
Hey, Peter, if I may, I want to go back, though, to kind of the tax issue. There are differences in the House and Senate bills on kind of how to pay for health care legislation. Yes, so I'm curious, does the administration support either the Cadillac or the millionaire's tax?
Well, I don't want to get in the middle of the legislative process. What we have said is the bills must be deficit neutral. They have to be, over the first 10 years, they have to be better than that over the medium and long term, and they have to include a whole variety of important delivery system reforms.
So would you support it if it meant that this would be deficit neutral? Healthcare reform would be deficit neutral?
Well, I don't want to prejudge, this is a legislative process. We're further along in that process than ever before with regard to comprehensive reform. I don't want to prejudge the final outcome there. But what I will emphasize again, that any final piece of legislation has to be at least deficit neutral.
I wonder, you talk about as far as the cost controls, these academic studies from Dartmouth and other places, is there any real-world evidence from a country with more than 1 million people that suggests you won't see costs running out of control and people demand more coverage for more procedures?
Well, again, if it were just some academic or theoretical finding, that would be one thing. We have in the United States, whether at Intermountain Health or the Mayo Clinic or elsewhere, examples of healthcare systems that are currently delivering healthcare at much lower cost and higher quality than other places in the United States. What we need to be doing is moving much more towards the practice norms that are already prevalent at real-world places. You can go and visit them in the United States.
All right, excellent. Hey, Peter, thank you so much for joining us. White House Budget Director
Thank you.
Peter Orszag there.